Hello and welcome. My name is India and I am a project officer at GPEx. I begin by acknowledging the traditional custodians of the land on which we meet and pay my respects to their elders past, present and emerging. This recording is being facilitated by Karina Brown, who is a clinical educator at ShineSA on the topic of Hpv self-collection in general practice. This recording has been made possible with funding provided by Cancer Council SA and Wellbeing SA. So let's get started. Over to you, Karina.
Thank you, India. I too would just like to acknowledge that I'm presenting this presentation today on Kaurna land, and I'd like to welcome any other people who are listening to this from any other Aboriginal nations. So I'll just scroll through. So as India said, this is a joint presentation between GPEx and also ShineSA. And we are trying to help primary healthcare providers understand the role of self-collection in cervical screening. So I'm a clinical workforce educator, as India said, and we've spoken to a lot of people recently about these exciting new developments. So let's start. So just to give you a little bit of context, we can remember that in 2017, we went from the 2-yearly PAP testing and moved over to 5-yearly testing for HPV, human papillomavirus, to screen for cervical cancer. So that was a huge development that we moved from 2 years to 5 years. Then in early 2018, we started the HPV self-collection policy, which was fabulous, and that there were a few people that we could offer this to, but it had fairly strict criteria, and that was that you needed to be over 30, you couldn't be pregnant, and it was for people who were mainly underscreened or who had never been screened. It certainly wasn't for everyone. But the good news is that this is changing, and it changed on the 1st of July. So on the 1st of July, the clinical practice guidelines appeared on the Cancer Council website, basically they've put in a partial update to put in the self-collection method of collection. So we will have a look at some of those things now. So the update says that all participants, if they're within scope, will be offered the National Cervical Screening Program from the 1st of July with ongoing GP guidance. So they'll be offered self-collection, and this will include people with a cervix aged 25 to 74. So nothing has changed there with that timeline. That has not changed at all. You will remember back to the days when we did a pap smear. We started at 18, we then moved to 25, so 25 to 74, so that's exactly still the same. So that's good. So anyone who's eligible now will be offered the choice of a HPV self-collected sample or a HPV clinician-collected sample, unless a co-test is pre-specified. So, and we will talk about that and the need for co-testing. So just a little quick note about Medicare item numbers. So you will notice here that we've got 2 existing Medicare item numbers, so 73071 and 73. So both of those they've just added a bit too. There is no change to these numbers here, 72, 74 and 75. Down here, there is an implication that if self-collection would not be reimbursable by Medicare until November for anyone who's less than 24 and 9 months. So you will remember that sometimes we can offer cervical screening for someone who's had an early sexual intercourse or victims of abuse. So it can be offered early because they may have been exposed to HPV during that time. However, if they had a clinician collected sample last time, which is likely, then they need to have a clinician collected sample again up until November, or else it won't be covered by Medicare. And also follow-up tests, so 12 monthly. So if you're getting someone back for HPV other, so not 16 or 18, then a follow-up test if the initial screening sample was clinician collected, which is likely that it was 12 months ago, then that needs to be clinician collected again up until November. This will all make a little bit more sense as we move on. So what we need to know, so it sounds fantastic that we can offer everybody this, but sometimes it's not appropriate, sadly. So it's not appropriate if we need to do a co-test. And just to refresh what a co-test is. So a co-test is when we offer both a HPV test and then we work out if there's HPV there and then use the same sample to send off to a psychologist, not a psychologist, a cytologist in liquid-based cytology. So they have a look at that sample under the microscope and see whether the cells have changed. So if anyone's needing a co-test, that cannot be performed on a HPV self-collected vaginal dry swab. That's very important to remember. It's not possible to send that swab off for a second round of testing. So if someone needs a co-test, then that's not a screening test, it's a diagnostic test for a start, but they will need to have a clinician collected sample for a co-test. So let's try and remember, let's think about who needs a co-test. So it's good to know this. So basically anyone that's symptomatic, and we do have some lovely little guides for you to go, which you can get from the Cancer Council website, from those guidelines that I mentioned, and save as little favourites on your desktop, so you can refer to them to sort of guide you in what test to order. So symptomatic patients, so in particular, those presenting with unexplained persistent abnormal vaginal bleeding. So we talk about the big three here: post-coital bleeding or post-insertive sexual bleeding, so after sex, and that would be any type of sex. That would be sex with same sex partners or with heterosexual partners. But basically we want to know, why is during insertive sex, why is there bleeding after that? So what's going on with the cervix, if it is the cervix in fact. So unexplained intermenstrual, so at other times of the month apart from when they're menstruating, or postmenopausal, so after menopause. So the person's been menopausal for a while, or maybe only for a very short time, but they are declared as being menopausal and suddenly they're bleeding. So this is when we would order a co-test. Also, surveillance of patients exposed to DES in utero. So DES is diethylstilbestrol, which is basically it was a medication that was given to people between the times of, say, 1940 right up until the 70s. Those people gave birth if they gave birth to somebody who was female, they are known as DES daughters, and DES daughters have a greater chance of vaginal and cervical cancer. So those people need constant yearly follow-up, and we would always be offering them a co-test, because we need to, if someone's more prone to having those cancers, we need to be looking with a co-test to see if there are any changes on the cells. Surveillance of adenocarcinoma in situ, so that one's fairly straightforward. Of course, we would be doing the co-test to make sure that the cells are staying the same. And people who are undergoing a test of cure, so people who have been treated or a biopsy confirmed with a high-grade lesion. So on the website, you will see, when you look at the clinical guidelines, you will see this lovely little table which gives you a great rundown of who needs a co-test and who doesn't. So here we are. So here's everything I just said there is spelt out here. You can see this one, unexplained. So this one I've just spoken about, unexplained, persistent, unusual discharge. So this is not, this is not discharge where someone says, I think I have candida or I've had bacterial vaginosis in the past. These are the things, perhaps you've done those tests, it came back with nothing on it, but something's going on here and it's perhaps blood stained. So why is there bleeding and why is it so offensive? So we would run a co-test there. Also, deep persistent dyspareunia. Now we have another guide for this in a second, which is very handy. But also dyspareunia that's so deep, persistent dyspareunia, that is accompanied by bleeding. So what's going on there? Why is there bleeding? So we need to do a co-test to rule out that it's not the fact that the cervix has become compromised because of a HPV infection. If someone just came in with discharge and they were having a HPV test today, we wouldn't run a co-test for discharge. We would ask them about that and perhaps perform some other swabs, run some other swabs, but it certainly wouldn't be a co-test just for vaginal discharge. And also unexplained persistent deep dyspareunia in the absence of other symptoms. So you can see that the bleeding is the deciding factor here. And deep dyspareunia is quite common, especially when people become menopausal and things change. So we would only really do a HPV test there. So just a little bit of revision here to look at a few cervixes. So just to remember, so we've got somebody here who's never had a child, so a nullip. You can see the cervix is very small. We've got a cervix we often see with the younger persons. We've got that large ectropion, makes it very easy to see where you should collect cells from if you're doing a clinician collected. We've got a rather convincing case of Nabothian follicles here. So we would always, when we're documenting, if we're looking at this cervix, we would document that. And we would also, we've got a multiparous cervix. We've got a cervix that's atrophied, so we know that they're always a little bit more difficult to get those endocervical cells from, because this section has merged up and pulled back up inside as that person ages. Here we've got a polyp sitting there on the cervix, a cervical wart. We've got some discharge, cervical, so this is cancer. We've got some IUD strings here, so always good to document those strings, and also always document how long the strings are. So we need to do that so that if that person comes back a bit later, and then if you documented 6 months ago they were 3 centimetres, now they're 5 centimetres, well, this has probably moved and maybe the contraceptive is not going to be working anymore. This is a stenotic cervix, so where there's been an injury to the cervix, maybe treatment, or maybe there was a cervical tear during childbirth. And this is post-treatment, where the cervix can look very pale and very white. So this is a fabulous flowchart to do with the vaginal abnormal vaginal bleeding, because when we're doing testing, we need to know, I suppose, what's normal and what's not normal, and we need to know what to do with it. So this is a fantastic flowchart, and this is another one that I would save. So this is, so if we look here, we would always there's been some post-coital bleeding. So first port of call would always be to do a co-test, because there's post-coital bleeding. But this gives you a lovely little flow chart, a lovely little pathway. So HPV is not detected, and they've gone on and done the cytology, and it was negative. So it turned out it was just a single episode. You've checked out the cervix was fine. The person doesn't need to be sent for colposcopy because it was just a single episode. So perhaps it was positional, who knows, but it hasn't returned. Let's say that you did all of that and it was negative, but then it's recurrent and persistent. We're going to send them off for a gynecological assessment. Also, if there was a co-test and there was an abnormal result, so that HPV was detected and or an abnormal LBC result, then they're going to go off for assessment as well. These people over here, intermenstrual bleeding and postmenopausal bleeding, will do the co-test and send them straight for assessment. So when we talk, so the Cancer Council and GPEx have, well, the Cancer Council have come up with these practice points. So we're going to talk about that now. And basically, we need to inform people about this. And we expect that, and certainly I have myself seen a few people and conducted the self-collection already. And there is some nervousness around it, I think, just like there was back in the end of 2017 when the changes came in, and all of these people had heard about needing to do it every 2 years, and suddenly we're telling them to do it every 5 years, and now we're telling them that they can actually do it themselves. So we need to be very clear with them what we're doing, and we need to offer them we need to offer them a choice. Some people still will prefer a clinician-collected method. What's handy in all of that is to be letting people know why we're doing it. So approximately 2% will have, of all of the people that we test, will have HPV 16 or 18, and approximately 6% will have the other types of HPV, which we will look at, but which we manage differently. So we need to be very clear with them, and we need to give them informed choice about self-collection. Well, now, where can this be performed? So basically, this is talking about how and where we can do it. So the obvious place, of course, to do it is in your clinic room or in your clinic bathroom. It may be that at the same time you offer them an STI screen, so they can do a self-collection swab for that at the same time, which is very, very ideal and opportunistic. I think the benefit of doing it in your clinic space is that then you haven't ordered the test, and then you've got outstanding pathology which hasn't been returned yet, sitting in your results. So there will be an option, of course, to send people home and to do the test at home, because it's such a forgiving test, and we'll talk about that in a second. But it's a great opportunity to just send people off to the toilet whilst they're there. And it's a good opportunity also just to mention that Shine do the cervical screening training for nurses, and that some GPs find ways of then setting nurses up with this, and then so that they can try and get more of them, basically. So it really lends itself to a nurse-led model, working collaboratively with GPs. Okay, so this slide is actually talking about self-collection and where it can be done as well, and you will need to work with your pathology laboratories. In South Australia there are 2 that do this, and we will talk about that in a second. And of course it's only doctors and nurse practitioners who can sign the pathology request forms, but there are interesting ways that nurses are doing this, practice nurses are doing this within their practices and working collaboratively with GPs. So some people will have assistance with, will need assistance with the self-collection method, and it may be that you still actually need to do it for them, especially if there's a disability, and it may be that you need to do it with the speculum. You would still actually order it as a self-collection, on the request form. So this slide actually talks about people who are underscreened and need extra assistance. So we need to just take into account why those people are underscreened, and we will talk more about this, but we may need additional follow-up and support. We may need more reassurance, and we may need to really explain to them the procedures and the pathways. So for someone who's underscreened, they may be really happy that we can now offer them self-collection. However, they need to also understand that if this comes back with HPV on it, then we would be asking them to come back for a clinician-collected test. Routine genital inspection is not indicated with this. We don't need to do it. However, if the person actually gave you any information, you may wish to conduct a genital inspection and examination if there's something there that you're concerned about, or if the person is at high risk of vulval disease. Follow-up samples can either be clinician collected or self-collected, but as I just said, if a patient came back for a 12-month follow-up and all they would give you is a self-collected, that's better than nothing. However, they still need to understand that if HPV comes back on that, we'd be asking them back again. So it's probably wise to think about your consenting process there, that if it's, say, a 12-month follow-up and it's going to be sent off to cytology if it's got HPV on it, we cannot do that on a self-collected swab. So the consenting process around saying maybe it's best to consider a clinician collected in this, with this, then that's probably worthwhile considering. So in thinking about underscreened people, of course, Aboriginal and Torres Strait Islander people are underscreened and overrepresented with the burden of disease. So cervical cancer is twice as prevalent in Indigenous people compared to non-Indigenous people, and they are more than 3 times likely to die from this disease than someone who's non-Indigenous. So we really need to think about self-collection as a way of trying to change that statistic. So opportunistic, off to the toilet, off you go, and hopefully this is where some of the rates will hopefully change. Screening rates are also much lower than for non-Indigenous people, estimated around 38% compared to 56% for the general eligible population. And cervical screening, we need to remember, and I'm sure that all of you working in Aboriginal health, of course, know that there's women's business and men's business, and that we need to try and be as culturally appropriate as we can within the confines of our busy GP practices, and that there's also this feeling of stigma and shame around anything to do with sexual health, and also the associations with cervical cancer. So it's about trying to work with those people and trying to find creative ways of working through that. So one way, of course, is female clinicians, and I know that that's not always possible, but this is where nursing comes in and utilising nurses. Every state in Australia teaches cervical screening to sexual health nurses. And using culturally sensitive props in your art and posters, in your spaces to try and welcome Aboriginal and Torres Strait Islander people into your space, and also, you know, being aware of language barriers. So asking, is there anyone they need to bring to the appointment with them? The last point there is Aboriginal health workers. So if you can try and connect with Aboriginal health workers, that is really a fantastic way through this. So if you can get any Aboriginal health workers working with you, perhaps, I don't know, I mean, you know, people collaborate in all different ways, but that is the way to get more people screened, basically. So it's really important that you ask all patients whether they identify as Aboriginal or Torres Strait Islander. And the reason for that is that we need to record it on the form, and whether they are Aboriginal and Torres Strait Islander will actually affect the clinical management of the tests. So it's very, very important that you ask that. So one of the questions that we actually get asked is whether the testing holds up, basically, and is it as specific and is it as sensitive as a clinician collected test. In the Cancer Council guidelines, you will find the study by Arbin and others in 2018, which looked at self-collected samples and the efficacy of them, and as compared to PCR. And they found that they were just as sensitive as PCR. And also, interestingly, and here's the clincher, the adherence to follow-up amongst people with a self-collected sample was much higher. So that is incredibly encouraging. So we have some case studies for you. So have a look at Annie. Annie is a 41-year-old experiencing deep dyspareunia for several months. She thinks she may have some postcoital bleeding over the last 6 months. She has had 3 sexual partners in the last 6 months, and her last pap test was 12 months ago. So think about Annie. There's a few things going on there for Annie. So is Annie eligible for a self-collected sample, and what test should you request? So you should be thinking by now that no, she's not eligible because she is symptomatic. And what will we request? Well, we will request a co-test. She had some bleeding, didn't she? She had some postcoital bleeding. So we're going to want to see if that's because the cervix is compromised due to HPV, and that the cells have then gone on to change. So they're going to look at the cytology as well. We're going to also order STI screening. She's had the 3 sexual partners in the last 6 months. You would also order a transvaginal pelvic ultrasound. You would consider a pregnancy test and consider whether contraception is a cause of any of this. So the screening results come back, and HPV 16 is not detected. HPV 18 is detected, and HPV not 16 or 18, sometimes reported as HPV other, is not detected. They then sent that off to cytology, and she came back with a high grade. And it was a good sample, so they got to see the endocervical component. So they've really, they've got everything that they needed there. So what would the recommendation on the report say, and what are the key points that we need to convey to Annie? So it's really easy. If someone's HPV or 16 or 18, that's the easiest pathway of all because it's straight to colposcopy. What are the key points that we need to be conveyed to Annie about her results? So we need to explain that she has a higher risk of developing a significant cervical abnormality, that she has a high-grade lesion, and it's not the same as cervical cancer, but the cells look different and further testing is required. We need to explain the colposcopy procedure, so a little bit like you know, using the speculum probably takes up to about 10 minutes, can involve a biopsy, will involve acetate on the cervix to look at the lesion, and then we will talk to her about the results of the results will determine the follow-up. So a pathology update here. So which swab should I use? So we use the Copan flock swab. So the flock swab, so it's important to know that you don't use any old dry swab that's sitting out the back. You actually use the proper flock swab. And we've got a picture of that in a second. It's this swab can be given to the patient, and then they go off to their to the clinic bathroom, or they do it in their home. And independent studies have proven that the use of the Copan flock swab improves the quality of samples collected, a high level of reliability, reproducibility, and repeatability has been demonstrated. So this swab is very tough. So this is the picture of our swab. There's no breaking involved. They basically just open it, insert. Please let them know to insert them as far up as a penis would go if they're having heterosexual sex, or as far up as they can possibly put the swab without it being a torture test. Move the swab around sometimes, and they do actually have the directions of these, and we'll show you those in a second. But they put the swab up and around and use the swab to collect, and then just back in there, back in the little tube. So the swab is amazing because it's not sensitive to heat or light and does not need to be refrigerated. So this is really amazing. It's really forgiving. The turnaround time from when the sample is taken to when it must arrive at the lab for testing is 28 days. So I think we can safely say this is an extremely forgiving swab. The time frame is about the same for home-based self-collection. However, we need to make sure that if people do take it home, that you ask them to write the date and the time that they took the sample on their tube. So in South Australia, the only options we have at the moment are ClinPath, or and so you would contact ClinPath or you would contact the Victorian Cytology Service. Both of those providers are well versed in using self-collection and will work with you, even if there's not. I mean, with Victorian Cytology Service, that's all through the post. That's all done through the post, and they will work with you very closely to get your service set up wherever you are. And so this is why, so with the 28-day turnaround, this is why this is so fantastic for all of you people in remote areas as well. To keep updated, clinicians should stay in touch with their usual pathology provider. So there is talk about other pathology providers beginning this, but as yet we can only announce that VCS and ClinPath are doing it in South Australia. So the most common reason, we still can have an unsatisfactory or invalid result, and the most common reason for that is insufficient cellular material collected. So maybe the swab was not inserted far enough. Other reasons may be due to inhibitory substances, so blood, inflammation, or lubricant. In contrast to the Pap test, so with the Pap test, they used to be able to tell us why. They will no longer tell us why with this. Why was it invalid? They won't tell us. They're not going to look at that. They're just going to tell us it's invalid. But mostly it's due to the fact that they didn't get enough of the cellular material. So when people are coming back and they're repeating it, we need to ask them if they had any difficulties with the previous swab. A clinician-collected sample could also be offered at this point. If an unsatisfactory result is returned and it's a self-collection, they can do that again immediately. If it was a clinician-collected, it's still the same. We just wait 6 to 12 weeks. So managing the results. So we tell people if they've undergone if they've had a self-collection sample and HPV was not detected, then it's still the same. They're invited to rescreen with a HPV test in 5 years. So what a fabulous thing that it can now just simply be going off to the toilet, doing the swab yourself, and then you come back 5 years later and do that again. This is a very helpful slide. We're about to talk about when people are getting results of HPV in 16 and 18 and HPV other. So this is a really helpful slide, I think, for clinicians just to take some take-home messages from this about HPV infection. Often it's quite common that we ring someone and tell them that let's say they might have HPV not 16 or 18 but HPV other, and they're within scope to come back in 12 months time to retest. Then often they will become very stressed with that phone call. So it's really good to remember just how long it actually takes for something to move towards cervical, to actually be diagnosed with cervical cancer. This is a very slow growing cancer. And also within that time, we can have viral clearance. So we've got viral clearance right up to here. So we can actually, the virus is either going to go one way or the other and can go either way during that time. So a person's natural immune system could come into play here and clear the disease. So it's very important to remember that when you're talking to people, that they can clear this disease themselves. Of course, if they're over 50 and their immune system is starting to wane a little over 50, if they're immunocompromised, so if they have a reason that they can't fight infection, that would be a little bit different. But it's very good to remember this process when you're talking to your patients. So I'm going to talk about this right now. So we're going to talk about what do I do? So what do I do if HPV is detected but it's not 16 or 18? And there are some changes amongst this. So for people who have HPV and it's not 16 or 18, then we're going to ask them to come back. They did a self-collection and we're going to say, can you please come back so we can do a clinician collected now and have a really good look at those cells. So we're going to send this off for a liquid-based cytology now because we know that they've got HPV, so all we now need is a liquid-based cytology. If that then, of course, demonstrates invasive cancer, then we would send them to an urgent gynecological oncology referral, ideally seen within 2 weeks. If the liquid-based cytology demonstrates a possible or a definite high-grade lesion, then or if there's any other glandular abnormality, we would refer for colposcopy, preferably performed within 8 weeks. If their LBC is negative or demonstrates a possible or definite low grade, so it's only a low grade, we would repeat that test in 12 months. Now, at the 12-month test, So that person's gone away for 12 months and has come back now. So if at the 12-month test, the oncogenic HPV is not detected, fantastic. Then we're going to return to 5-yearly HPV screening. So in that time, their immune system has kicked in. They have got rid of the HPV, and we can now safely return them to 5 years. So at the 12-month test, if 16 or 18 is detected, well, that's easy. Remember, 16 or 18, straight to colposcopy. So they're going off to colposcopy. At the 12-month test, if HPV any type is detected and the patient is aged 50 years or older, is from an Aboriginal or Torres Strait Islander community, or is overdue for screening by 2 years at the time of the initial screen, we're going to refer them for colposcopy. So the reasoning behind that, we know that people over 50, like I said before, immunity starts to wane. We know that with Aboriginal and Torres Strait Islander people, there are sometimes other things going on there. We need to act quickly. We need to prioritise. And also, if someone's overdue for screening, we don't know how long the HPV has been sitting there. So they're going to go to colposcopy. If at the 12-month test HPV not 16, 18 is detected, other than in the patient groups listed above, so let's say it's a 27-year-old who's healthy, a 35-year-old is healthy, and the liquid-based cytology is negative or demonstrates a possible or a definite, then we can give that group the extra 12 months. So there's two groups. This is the first group. They get 12 months. The second group gets 24 months. If at the 24-month test, if any HPV is detected, it's to colposcopy. If at the 24-month test, if no HPV, return back to 5-yearly screening. And these pathways are on the Cancer Council website. So, like I said, if it's 16 or 18, it's so straightforward. It is straight to colposcopy. There's no need to do a LBC, because this will be done at the colposcopy visit. Yes. If the initial sample for HPV testing was clinician collected, then they will also do their LBC, and that will be done there. And there's that flow chart, but that really is the easiest one of all. And on the Cancer Council website, within the guidelines, this is another fantastic pathway flowchart for you to save. So you can just go in, because sometimes it does get a little bit confusing. So you can go in and have a look at all the different pathways. So here we've got not detected, not 16 or 18, so the 12 months or the 24 months, or the H16 detected, straight to colp. And this is what we do for an unsatisfactory. So it's easy. So when to refer for colposcopy? So when there's HPV 16 or 18 detected, HPV not 16 or 18 detected, and possible or definite high grade. So then we need to go to colposcopy, because it's not 16 or 18, but we've got a high grade. So negative or possible definite low grade lesion, persistent across 2 tests. So we gave them, so this is for the index test and the 12-month. The patient was unscreened. This is everything I just spoke about, really, or overdue for testing, or from an Aboriginal and Torres Strait Islander community, or is 50 years or older. Then they are going to go to PULP, or persistent across 3 tests. So that's just really everything I spoke about rounded up. Screening participants aged 70 to 74 with HPV any type is detected, then we are definitely going to send them to COLP. History of immune suppression and HPV, so of course we're going to send them to COLP because they're immunosuppressed. And a history of death exposure and HPV, and we know that those deaths, people have a higher chance of cervical and vaginal cancers. So let's talk about Asha. Asha's a 25-year-old university student returning for her cervical screening results. Results from her first screen are HPV 16 not detected, 18 not detected, but she has not 16 or 18 detected. So she's 25, and so she's going to fall into that group where we're going to give her a couple of years. So no evidence, we've done the LBC and there's no evidence of any changes, and it was a good sample. We got those endocervical cells. What should the report say? Well, I probably just gave some of that away. So repeat HPV test in 12 months. So we need to tell Asha, come back for the results, explain that HPV is very common. In fact, we refer to this as the common cold of sexual health. So avoid terms like STI and infection. Most HPV clears naturally with your immune system. Retesting is required in 12 months to see if it's cleared. If HPV does not clear, she will need a special test eventually called a colposcopy, and no need to inform current or future sexual partners. So Asha returns 12 months later for her cervical screening test. What test needs to be repeated today? So she comes back for the test. Now, if she chooses to have a clinician collected, if she opted for a self-collection, that would be fine, but it would not be covered by Medicare until November the 22nd because she had one 12 months ago. So we're going to perform the HPV, and this time we find that not 16 is detected, but now she's got a possible low grade. So she's had the 12 months. She didn't clear it in that time, but that's okay. Possible low grade lesion here, and it's a good sample. So the fact that really the cells it's still low grade. She hasn't cleared it, but we know that Asha is healthy. We know that she's 25. She doesn't fall into those other categories of being over 50, all of that stuff. So we're going to give her, let's see what the report says. We're going to give her another 12 months. So previously we would have got her straight back for a colposcopy. That's now gone. We're going to repeat the HPV in 12 months because Asha is healthy and hopefully her immune system kicks in during that time. So direct referral to colposcopy is recommended if we're these things, and we just spoke about that. So what if it still comes back positive? And I think we might know the answer to that because I've consistently given it away. But any HPV detected, then they will, of course, do the reflex cytology if it was clinician collected. If she only agreed to self-collected, we would have had to have got her back again to do the clinician collected, and they will refer for colposcopy. If no HPV detected, return to 5-yearly screening. So let's talk a little bit now about underscreened groups. Underscreening is the biggest risk factor for cervical cancer, and I cannot stress that enough. This next point is really, really phenomenal when we think that Australia will be the first country is on track to eliminate cervical cancer by 2035, but only if we address the existing inequities. Now, that's in access to screening and timely diagnosis and screening. So this is where self-collection is just so exciting, and that is that it offers a pathway for those underscreened groups. So the people who you just could never get in there now are coming perhaps for something else, and this is a quick opportunistic test in the toilet. So that it is believed that that is the thing, that self-collection for HPV is the tool that's going to help us eliminate cervical cancer by 2035. So who are under-screened groups? And many of you listening to this will probably know who they are because you're working in these areas. So of course, people living in rural and remote areas, and I know myself living in a rural, living out in the desert, and we would only have somebody, the Royal Flying Doctor would come and do a clinic every 2 weeks. And of course, those clinics were always taken up with probably more pressing issues rather than screening. So Aboriginal and Torres Strait Islander people from cold backgrounds, people living with a disability. So there are no surprises with any of this. People who identify as LGBTIQ and have a cervix, people who have experienced sexual violence, assault or abuse. We need to be mindful of those people, that this is perhaps a triggering thing for them to do. People who have undergone female genital mutilation or cutting, the same. People experiencing socioeconomic disadvantage, people who are homeless or with addiction or in custody, people who have had negative cervical screening experiences. So we need to be quick to let them know that now they can control this themselves and go into the toilet and be in control of that. People who are older and people who are very overweight. So all of these people, we need to put more services around them and put them on our radar. And this is what will get us to that wonderful statistic of eradicating cervical cancer by 2035. So what we've got now is a video for you, and the video looks at Claire and Claire's partner, and Claire is from the LGBTIQ community, and she talks about how long it took her, her last cervical screen was and the outcome of that. So please have a look at the video and have a think about that and the communities who you are working with and their access, and how their access to self-collection could change underscreened communities.
My name's Claire, I'm 42, I live in Melbourne, and this is my wife George. And yeah, I did the self-collect test, and that's how I found out that I had cervical cancer. Back sort of 20 years ago, doctors were kind of like, if you identified as LGBTIQ+, that you didn't need to get those tests because it wasn't so much of a risk for you to have cervical cancer. It had probably been 10 to maybe 13 years since I'd had a test previously. I think, you know, at that point in time, I just kind of did it to stop my doctor from badgering me. From that point, things happened very quickly. The next thing was that I got a letter from the Mercy, the hospital, women's hospital in Melbourne, asking me to come and do further screening. And from then, pretty much on first look, the oncologist was like, he knew it was cancer straight away. You know, at that point in time, he was like, the best outcome is that you will have a radical hysterectomy. Hearing that at the time, that's pretty intense information. I had a radical hysterectomy, therefore didn't have to have any chemo, which was amazing. It was a really good, clean surgery. Straight after surgery, maybe 2 days later, I found out that I was completely cancer-free. That was the best outcome that could have happened. So the self-collect test you can just do in the privacy of the cubicle at a doctor's office is how I did it, rather than doing it with the doctor. And I think that it was less invasive, not painful, less kind of being exposed. Yeah, so I think it was just it was easier to do. Go to a doctor that will offer you that as a test, because for me it was the difference, well, to be dramatic, is the difference between life and death. Like, it's better to go and get that test than no test, and I think that I am kind of proof that why that test is really important. To know that it can be done really easily and really quickly and really painlessly, you know, you're just going to go and do it, which is what I did and how they found my cancer.
I was amazed when she came home and told me about the self-collection, that was even an option. And when she ended up finding out that she had cancer, I realised that I'd never had a pap smear. And that was the first thing that I went and did. I was like, okay, self-collection, let's go. So yeah, very relieved that that is accessible for us. Definitely get it done. It's comfortable, you get to do it yourself in private. It's not painful, it's really easy to do. Yeah, would recommend.
Definitely within our community, our friends, we've spoken about a lot of our friends who identify as LGBTIQ+, including trans men, is a really big area of underrepresented people being tested for cervical cancer. And I would say that this test exists and you can go and ask your doctor to self-collect, and you should make sure that you're looking after that part of your health and find a doctor that will do that.
You know, in a moment our life changed, but it's all good now.
It's all good now.
Because of the self-collect.
Go the self-collection. Yeah.
So identifying underscreened patients within your practice. So this practice point talks about using the software systems. For an example, best practice, and I know a lot of people do use that. That has a specific tab or location where CST results can be recorded, but also if the results of cervical screening tests are not transferred to this specific location, using things like reminders and recalls and finding ways through of doing that. So using your clinical audit tools to help you find the people who are due. Of course, we also need to remember in all of this the National Cancer Screening Register. This is a fantastic register which houses, bowel screening and cervical screening. So you can access this through Proda. And you can very quickly have a look at your patient's past results on this. We need to remember that people will be followed up by the National Cancer Screening Register, and it can be used in conjunction with your databases. So this is another way, again, of finding those patients and when they were last screened. Also, just a quick word that it's very important to know when they were last screened, and sometimes patients can't remember. So checking the register through Proda takes between 1 to 2 minutes once you've got it up. It's something that you could ask nursing staff to do and let you know, because if the screening is done too early, so if they're not actually due, say it's 4.5 years and they were due, let's say at the end of December this year, that would be exactly 5 years, but they've come now and they can't remember when their last one was, well, they're not going to be eligible for a cervical screen. But they will be eligible in December because that's 5 years since their last one in 2017. So they will actually get a bill for that. So you've got to be pretty clear on when they had their last one. But using Proda and seeing the National Cancer Screening Register is a way of doing that. So identifying and modifying barriers in your practice to cervical screening. So there's patient barriers, systems barriers, and provider barriers. And when you think about some of the barriers in your clinic, we've presented this to other people, and some of the things that came up with these things, so accessibility of services. So it's difficult to sometimes get people at the right time. We've spoken about a culturally safe practice. We've spoken also having the right software, cost to clients, inadequate or lacking reminder systems. So that's another thing. So, and for the patient, time constraints, they just thought they were going to be here for 10 minutes. Past histories of abuse, non-culturally sensitive areas, lack of knowledge about why they need to do it. This would particularly apply sometimes to cold people where in their country of birth there is no cervical screening sometimes. So this is all new to them. It's not a high priority. There are many other things in their healthcare that they need to look at. Previous negative experiences, as we mentioned, fear and diversity barriers. So not an inclusive practice. Also time constraints, so inadequate records, time constraints for the provider. And of course, we know that people turn up with many, many issues, and it can be very difficult to fit that in to a very, constrained GP appointment. Perceived lack of financial incentive, lack of confidence in performing CSTs, lack of awareness of self-collection pathways. Hopefully after this, you'll feel better. Lack of training in culturally safe care. concerns that some people will only see female practitioners. And let me say once again, this is a really great thing for nurses. So there's ways through this by using nurses. As I've said, every sexual health agency in Australia has a cervical screening training program. And also discussing cervical screening results with unscreened patients. So we need to build trust. We need to offer longer appointments. We need to demonstrate respect. We need to remember trauma-informed care. And I know that you all realise what that is, but it's understanding that people could maybe not turn up to that appointment because it's a difficult one to turn up to not make assumptions about cultural background, sexual history, sexual preferences, literacy levels, or patients' knowledge of their body, and to always use interpreters if language is a barrier. So offering HPV self-collection, what do we need to address? So we need to talk to them about what HPV is. So sometimes it's good to use those analogies like it's the common cold of sexual health, and a lot of people have it. So trying to destigmatize it, and the importance of regular screening. What is a self-collected test, and discuss the high levels of accuracy. Clear instructions. Now we will look at that in a second. Both of the providers who offer this in South Australia send a bag with the instructions in it to help you. We just point to images if you don't feel it's culturally appropriate to use anatomical names. Potential outcomes based on possible test results. So we need to prepare our patients for the results. And here are those cards. So there's ClinPath on the right and Victorian Cytology Service on the left, and they're pretty clear. So you can just point to the pictures. Or this, like I said, this could be just something for a practice nurse where they take them off into a little room and just have a little bit of a chat on how to do it. So we're getting towards the end now. So we're looking at Ashley. She's 28. Ashley's a 28-year-old patient who has never had a cervical screening, and she is interested in the option of self-collection. She doesn't have any symptoms of concern. So we know that we're not going to talk to Ashley about having a clinician-collected sample because she hasn't told us anything that's going to make us want to do a co-test. So we can go ahead now and do a self-collected sample. So how will you describe the process of collecting the swab to Ashley? Just have a think. We're going to talk to Ashley about where she can perform it, what type of swab it is, when does the swab reach the lab, what happens if it's not 16 or 18, what happens if it's HPV 16 or 18, what will you advise her? If Ashley's results are unsatisfactory, what advice will you provide next to her? It's good to think about these things. How will you describe the process of collecting the swab to Ashley? So we've talked about these things now. So we're going to we've really just talked about those, and all of those things that we talked about in this webinar, we're going to bring those now into our answers. So we're going to talk about the 28 days, and we're going to tell Ashley that we'd like her to come back best for a clinician collected sample, because HPV, if it's HPV not 16 or 18, it's best to come back for a clinician collected sample so that they can actually do the cytology. So recommend, and if it's 16 or 18, it's recommended direct referral for colposcopy. If Ashley's results are unsatisfactory, we know that that a sample, if it's clinician collected, can be repeated in 12 weeks, or if it's self-collected, it can be done straight away. So that's really just a quick summary of everything that we've spoken about. So here's our summary. So self-collected HPV tests to be offered to all eligible patients in the National Cervical Screening Program from the 1st of July. So this is hooray to try and eradicate cervical cancer by 2035. We're never going to do this if a co-test is required. If someone's symptomatic, they need a co-test. We're never going to do this if they're a DES person or if they have adenocarcinoma. And we're never going to do this if they need a test of cure. That is the end of the presentation, and I would like to thank you very, very much for listening today.